Hello, everyone. Welcome, and thank you for joining us for today's virtual learning hour on workforce safety in the age of COVID-19. My name is Sarah. I'll be your technical host for today. So if you have any technical questions or concerns, please chat to me directly, and I'll be happy to assist you with those one-on-one. We'll be using the chat, which is a great place to submit any questions or comments you have throughout today's presentation. To do so, first open the chat box. There's a bubble at the bottom of your screen that you will click, and it will open on the right-hand side. Please be sure to chat to all participants when chatting in questions so everybody can see them. Today's program has been accredited for one contact hour for nurses, physicians, CPPS recertification, and healthcare executives. All faculty have disclosed in accordance with the rules and regulations and have nothing to disclose today. Here's the criteria for completing the program in order to be able to claim the continuing education credits mentioned earlier. Register for the event, log in and participate in all of the event, which we're currently doing, and complete the online evaluation, which will be sent out after the event, along with additional instructions to claim credits. Our objectives for today are to categorize key safety principles and measures for protecting the healthcare workforce through the phases of the COVID-19 pandemic. We'll deploy programs and initiatives to optimize the well-being of the healthcare workforce and describe how lessons learned from the COVID pandemic can be applied to accelerate your organization's overall progress in workforce safety. I'll now hand it over to Madge Kaplan, the Director of Communications at IHI.
Thank you, Sarah, and thank you all for joining us. The COVID-19 pandemic has magnified pre-existing risks of illness and injury for the healthcare workforce and necessitated some real-time adaptation and rapid cycles of innovation and improvement to address and mitigate workforce harm. Today, our panelists, and they include Jeffrey Board, Kathy Gerwig, Mary Beth Kingston, and Patricia McGaffigan. They're going to discuss practices, programs, and leadership considerations for advancing the safety and well-being of the healthcare workforce. They'll focus on the current COVID-19 landscape as well as a rapidly evolving and uncertain one. And let me say a little bit more about each of our panelists. Patricia McGaffigan serves as Vice President of Patient Safety Programs at IHI. She's IHI's Senior Sponsor for the National Steering Committee for Patient Safety, and she's liaison to its Workforce Safety Subcommittee. Jeffrey Board is the Chief Quality and Safety Officer at Parkview Health. He provides oversight of the quality and accreditation there, safety and infection prevention departments, all at Parkview Health. Mary Beth Kingston is co-chair of the Workforce Safety Subcommittee of this National Steering Committee for Patient Safety, and she has been Chief Nursing Officer for Advocate Aurora Health since April 2018. And Kathy Gerwig joins Mary Beth as co-chair of the Workforce Safety Subcommittee. Kathy served in national executive roles for over 26 years at Kaiser Permanente. So at this time, I'm going to hand things over to Patricia McGaffigan to get today's virtual learning hour underway. Thanks.
Thank you so much, Madge. And I'd like to kick things off today by setting some additional context for the importance of our discussion on workforce safety. Some of you may be aware that 2 years ago, IHI convened a National Steering Committee for Patient Safety. You heard reference to that in the introductions. The charter of this committee is to develop, disseminate, and steer the future course of a national action plan to advance patient safety. And it's been one of the most important safety initiatives that we've undertaken in the history of IHI, and also that we have collectively undertaken in the broader world of patient safety. On the committee, we engaged 27 members, and these include patient and family representatives, 7 federal agencies, and a number of prominent healthcare associations and healthcare delivery organizations. And one of our critical guiding principles of the several that we establish has been our shared commitment and core value on equity. You can follow our progress on this work through the link that Vicki will be chatting on into the virtual learning hour. Now, in our work to develop the National Action Plan for Patient Safety, which we expect to release in September, the committee engaged about 80 subcommittee members, a very diverse group of subject matter experts, to develop recommendations, tactics, and an implementation guide for 4 focus areas that the committee deemed essential. These focus areas all have critical interdependencies, and they create a fertile soil that will allow broader safety initiatives to take root and be cultivated. The 4 focus areas of the work of the committee include culture, leadership, and governance, person-centered care, learning systems, and workforce safety. Of note, our focus and commitment to workforce safety had already been well established and evolving because there's an inextricable link between patient and workforce safety. So prior to the pandemic, we were working on this, and we also had the need to address patient and workforce safety from a unified perspective as compared to siloed perspectives that exist. The National Steering Committee has also reviewed the recommendations in the context of what we've learned during the pandemic, and we validated the relevance of those recommendations and have added and reflected on lessons learned from the pandemic. So in the nature of our discussion today, as Madge has so beautifully introduced, let me turn things over to our experts, beginning with Dr. Jeffrey Board. On to you, Dr. Board.
Thank you very much. It's a real privilege to participate in this virtual learning hour today. As Madge said, the pandemic has placed workforce safety for healthcare and many other industries in the national consciousness like no other time in modern history. Frontline healthcare workers and leaders experienced, most for the first time, having to operate under crisis standards of care. In the United States, we in the healthcare industry found that in many ways we were not adequately prepared for what the pandemic brought us. For healthcare workers, it has been a time where they personally have had to carry the daily burden of wondering, will I get sick? Will I die? Will I bring this illness home to my family? Sadly, many healthcare personnel have lost their lives to COVID-19. The Centers for Disease Control provides regular updates on numbers of cases among healthcare personnel, including as of June 24th, over 84,000 healthcare personnel have been afflicted with COVID-19, and there are over 460 deaths. And this is actually a significant underestimate of the true number because the CDC only have data on the occupations of only a fraction of the positive cases. The U.S. Department of Health and Human Services Office of the Inspector General released a report in April about hospital experiences responding to the COVID-19 pandemic. Two of the most significant challenges were keeping staff safe while caring for patients with known or suspected COVID-19 and meeting the needs and assistance related to obtaining personal protective equipment. And what they cited based on a large survey in that report were that the big challenges were a lack of access to testing, which limited the ability to monitor health of patients and staff. This created extended lengths of stay, which strained bed availability, PPE supplies, and staffing. There were widespread shortages of PPE that put staff and patients at risk, and hospitals were not always able to maintain adequate staffing levels or to offer staff adequate support. Exposures to occupational hazards is a fundamental method of protecting our workforce. And the hierarchy of controls has been the core framework to determine how to implement effective control solutions. We apply the framework to eliminate hazards and control risks to workers at an acceptable level. And we want to do this at the source or as early as possible in the process. We prospectively do this in the design of the work environment through inclusion of prevention methods in the design of the workspace and work processes. The pandemic has really caused us to see the gaps in our hierarchy of controls and our care settings, and that has led to a lot of rapid redesign and retrofitting. So as you can see there, the hierarchy has elimination at the top, and this is physically removing the hazard, and that's such things as virtual health or working, screening patients and employees for symptoms before they come on site. Engineering controls include examples such as negative pressure rooms or physical barriers to help isolate employees from a particular hazard, in this case, a respiratory pathogen. Administrative controls are operations. How do we change the way people work to reduce the risk of exposure? And examples of this include social distancing in the workplace, changing traffic flow, hand hygiene, having a program for cleaning of high-touch surfaces. And then finally at the bottom, we have PPE, and that's sort of our last line of defense. And this has really been a major focus in the public eye as we've wrestled with the pandemic because of the shortages. But it's easy to overlook the importance of all of the other layers of the hierarchy of controls to help us keep our workforce safe. So what are some key lessons that we've taken away so far with the pandemic? Well, one thing is this concept of safe worker and safe patient. Really, the pandemic has highlighted more than ever before the critical interdependency of the safety of our workforce and the safety of our patients. We have to keep our workers safe so that they can take care of our patients in a time of greatest need. PPE and supply chain became a daily concern in our health system at the highest levels. We were looking at this on a daily basis, and we had to implement very robust controls and really treat PPE as a vital and scarce resource. And it really became a key constraint that fundamentally changed how we delivered care. Radical flexibility. We had to redesign our work. So one example is one that you see here. And this is a picture that I took in our medical ICU at our largest hospital. And what you see is an IV pole. It's actually outside of the room. And so this was an innovation that our critical care nurses developed in collaboration with our intensive care providers. And this allowed, for COVID-positive patients, this allowed our nurses to be able to safely manage and titrate intravenous infusions while staying outside of the room and taking advantage of the physical barrier that we had in place with the sliding door. Now, we had to look at this and do it carefully because we didn't want to introduce new risks. For example, you have to have much longer tubing, and that increases the amount of what we call dead space volume, which can affect how medications are delivered. So we had to very carefully balance those risks so that we can not only mitigate the risk of exposure to the nurses at the front line, but also make sure that we can continue to safely administer medication to the patient. Managing fear and risk really became a daily thing. So we had to think about risks and every day make decisions about how to mitigate it. And all through this, we were all dealing with this torrent of new information, and sometimes the information was conflicting. But we really had to make sure that we acknowledged, validated, and openly discussed and dealt with the fear and concerns that our frontline coworkers and leaders had in coping with the pandemic. Communicate, communicate, communicate. So this became a really crucial component of our response through our incident command center structure. We communicated in many ways, and we communicated more often and with greater bandwidth than we ever had before. And that was so crucial to be able to help our frontline with all of the new information, with the radical change and everything that was going on around them. It also became very, very important for us to really embrace learning systems. And we really became, in healthcare, an all-teach, all-learn community. There was so much that we learned, and people were openly sharing with each other. If someone developed a new process or protocol, often they were just very willing and able to share that, posting it online, new treatment protocols that immediately got posted online, made available so they could be quickly adapted to help us take better and safer care of our patients. The pandemic has really given us an opportunity to build trust. And we had to be very transparent with our frontline coworkers about things like PPE and the real constraints that we were operating under. And the key was to be honest and truthful and tell them everything that we were doing to not only conserve PPE, but identify alternative and equivalent sources to assure that they remained safe and they had what they needed in order to safely take care of the patients. And we had to provide that clear source of truth and transparency. We also had to communicate with our local community, local government, and other organizations and stakeholders about how we were responding to these challenges in the pandemic throughout the course. And it was really an opportunity for us to build trust, both internally with our own coworkers, line, and then also with our community at large. But we also know, looking out nationally in the media, there were times where organizations really struggled with this. And in fact, trust became eroded, that there was a loss of trust between employees and hospital organizations about things like PPE and protecting coworkers. Finally, we had to make it easy to do the right thing, and it's really about helping our frontline coworkers understand and apply that hierarchy of controls, understanding what PPE to wear and when, and also making it easy for them to stay home if they were sick. Also make it easy for them to do remote work. We actually we have 13,000 coworkers at Parkview Health. We had over 4,500 coworkers working remotely within a few weeks with the onset of the pandemic and the stay-at-home order in our state of Indiana and in Ohio. Pulling all of that knowledge together as we shared it in the moment through various channels, but we really wanted to also bring this all together into a comprehensive playbook that we could share with our coworkers and with the larger community. And we looked at some really outstanding examples of safety playbooks that were developed by other organizations such as Kaiser Permanente, the Cleveland Clinic, Toyota Corporation, and Lear Corporation to help inform how we put our playbook together. We've been so grateful at Parkview Health in the outpouring of support and generosity that we have received from our community during the pandemic. And we really recognize an opportunity to share what we have learned with others and help them develop best practices to help other industries, organizations, and businesses safely reopen in Northeast Indiana and Northwest Ohio. And we really wanted to essentially build a community-wide learning system. And that's what we did with what we call Business Connect, where we partnered with other local and regional organizations, brought together as much information as we could about best practices, about safe workplaces, how to keep employees and customers safe as various businesses and organizations reopen, putting all that information together, making it freely available on a website, and then also providing, through our Parkview Business Connect program, free advice and subject matter expertise to answer questions from individual organizations to help them safely reopen. So finally, what's ahead? So we have been working on recovery, meaning going back to doing elective surgeries and admissions and outpatient visits while still being prepared and addressing the continuing number of new COVID cases that we have in our region, continue to help our communities with safe reopening, particularly our schools and colleges and universities as they prepare and make important decisions for the fall. And we've continued to need to support others impacted by the pandemic. As we know, the pandemic has had a disproportionate impact on those communities, minorities, and other vulnerable populations. And we need to reach out to them, providing mental health services, community nursing, and other essential support to reduce that disparate impact. We need to help all of our coworkers continue to work safely, both in the workplace and then also continue to be safe at home. We're working on strategic PPE restocking so that we are ready, particularly for the upcoming flu season. And we're already thinking about flu season because influenza is clinically indistinguishable from COVID-19, and this is going to create some important challenges for managing illness, both in patients and in employees, and we will need robust strategies in our health systems to be able to mitigate that. We also need to make sure that we keep our eye on the ball and make sure that we're mitigating those other forms of injuries, things like sharps injuries, sprain and strain injuries, workplace violence, as we continue to manage the pandemic. And then finally, planning for a future vaccine and knowing how we're going to implement our mass vaccination program once a vaccine is available so that we can protect our coworkers and hopefully be able to introduce widespread immunity in our communities. And with that, I will turn things over.
Thank you, Jeff. I am going to talk about deploying programs and initiatives to optimize the well-being of the healthcare workforce. And I will be using some examples from my own organization throughout. And I certainly don't have all the answers, but I do have some examples. So, of course, we all know the critical role that overall well-being plays in the health of our workforce and their ability to provide exceptional care to patients and families. But I have to say the pandemic brought this issue front and center, and it appeared even more multifactorial than it typically was. As Jeff mentioned, our care providers, everyone working in healthcare, have always known there have been some safety risks, but this is the first time they came to work every day worried that they might become critically ill and face death and place their families at risk. So these family and safety needs are a very large consideration. Psychological safety. Do team members feel they can speak? Did they feel they could speak out about their concerns, whether it was PPE, policies, or sharing ideas for improvement? Their overall physical health, sleep, nutrition, fatigue, all of these factors had to be considered. Financial health was a major thing that we looked at as well. As all of you, I'm sure, have experienced on the call, we canceled our electives. Many people were furloughed, this was particularly in the beginning. How would they be paid? Would they use their PTO? Would they have loss of salary? What about their spouses or significant others? Were they out of work given the high rate of unemployment? And lastly, the other factor I want to mention is moral distress and moral injury. Let me delve a little bit deeper into that. Oops. Hold on. There we go. I went the right way. Moral distress, of course, is knowing the right thing to do. You know what to do, but you're constrained by pursuing the right course of action. And we've seen this in the nursing literature and nursing practice, and certainly other care providers experience it as well. Some great examples are caring for a patient and you feel there's inadequate pain management, and yet you can't seem to get the response from others to change that. End-of-life decision-making. I think there's many things that have caused moral distress during the pandemic. Moral injury, and now this is a term that's often used more when you're talking about battle, but moral injury can occur in response to either participating in or witnessing behaviors that go against one's values or beliefs. And it seems to have had applicability in the pandemic. A great example would be the visitation issue. We had patients who were dying, and many patients died very quickly. We couldn't get family members in. We certainly had visitation restrictions and used all types of technology. But many, many people experienced, I would believe, significant moral injury by not having family members present because they are so committed to patient and family-centered care. And the pandemic, I think, really brought this again to the forefront because it had certain similarities to battle and to what we know happens after that, which is the potential for PTSD. At times, the pandemic was unrelenting. It was uncertain. There was a high personal risk. We didn't know a lot about this particular enemy. Certainly, fatigue played a factor, and a high number of fatalities. I mean, we experienced death in healthcare. We know that. But many times we would have in one unit six deaths in a 24-hour period. It just was at times very overwhelming with very little time to process, and also seeing disparities, seeing very vulnerable and diverse patient populations who were experiencing illness. So I'd love to say I have all the answers, but as this slide shows, it depends on who you ask, what's effective, and how people are feeling. Everybody goes through things differently, and so we needed to have a variety of approaches in order to address everyone's needs. We found, of course, the initial thing was addressing the immediate needs. Jeff mentioned exposures, and that was such a huge issue because I don't know about everyone else, but we have a wonderful employee health department, but in no way were they prepared to deal with something of this magnitude. And we had to spend a fair amount of time expanding that very quickly and then working with individuals who were reassigned so that they were doing the exposure management in a very caring and supportive way. I mentioned that we looked at the financial piece, and I think we were able to do some things that not all healthcare systems can do. We kept everyone whole. Anyone that was furloughed did not use their PTO. And eventually, when folks were quarantined, that happened as well. When children were all of a sudden not being in school, we were able to offer a child care supplement. This went a long way in developing that trust that people did feel that we understood what they were going through. And we did, and we were unusual in this regard, we did pay additional, what we call COVID pay for dedicated COVID units and the ED, and we are now phasing that out as our numbers come down. Our communication, and I think, again, Jeff covered this, I won't go into too much detail, but transparent, and we just had to admit that we were making the best decisions with the information we had at hand, and that would change sometimes on a daily basis. We had 2 email sites that were manned, and there was 24-hour response. One, again, in reference to what Jeff said about PPE, was specific to PPE, and then we had one for general questions. Early on, we developed our ethical decision-making process, so a decision tree for scarce resource utilization. I put this in well-being because it was definitely something that was on the minds of many of our team members as they heard about ventilator shortages and other drug issues, et cetera, in some of the other states. Again, we did not have to use it, but knowing that it was well thought out and that we could share it with individuals, I think brought a lot of comfort to many folks, particularly in the critical care areas. We recognized the physical needs, food. We had housing and, different types of deals with hotels and respite areas. I will say that the physical need piece was the one that people did not take as much advantage of, and I think that's because in healthcare sometimes we have this, we're not recognizing our own physical needs as much as we need to. Again, that community support, we shared that with everyone because that was more helpful than anyone could imagine. And then another thing that was very key was offering of virtual support groups. This was done in a number of ways through WebExes, through Zoom meetings, and also on demand for specific teams, issues, or leadership. We had tremendous participation in this. For our hospitalist one, we had 150 in attendance and eventually had to split that up. And then I don't want to underestimate the local support. There are individuals that said, I don't want to participate in a support group. They relied on their manager, and a big piece of what we did was work to support the manager so that they had the skills. Some people would do virtual, what we would call mocktail hours or health walks, and many of our team members felt that they wanted something that was specific and unit-based. And then The main thing, and I think that one of the biggest lessons is, we're all very concerned about the long-term impact. There was just an article in I believe it was in the New England Journal of Medicine, where they said this impact will be felt for years. Our pediatricians are talking to other pediatricians around the country saying children are going to be experiencing long-term emotional issues perhaps for many years. So we need to recognize this because of that moral distress and moral injury. Huddle packs, and I'll go through these quickly, are one thing we've developed. We're a huddle organization, and we develop them for leaders so they can address a number of issues, how to help people name their experience, recognize symptoms of stress, identify resources. And we have a number of resources for those leaders, whether it's specific WebExes on how to really talk to your teams. We have site champions that have been identified, and they are being trained in psychological first aid and trauma. We know we're not creating psychologists, but we are identifying people who will have some additional information, be able to identify and intervene and get people to where they need to be. And also using the Ohio State BEST program, brief emotional support training. Much of our communication focused on reducing stigma. Our theme was, it's okay not to be okay. And we have behavioral health, open scheduling for team members. Obviously, our employee assistance and mission spiritual care did a tremendous job with this. And this last slide just is an example. And you can, there is a link for this, and you can go into it and see examples of some of the things that we offered. This is just one bundle, How You Are Matters, the self-advocacy bundle. And, it's interesting because sometimes we think it's the big things. We've done a number of surveys and evaluations to see what worked, and it was a lot of these things that were in our daily communication tips, just helping people to talk about it, and also the support groups were the other thing that people found very helpful. So in summary, I would say meeting the immediate needs, providing channels for two-way communication, opportunities to discuss stress, feelings, and responses, and recognizing and planning for long-term effects. These are lessons that we'll incorporate into our everyday work now, and certainly have available for crisis situations should they arise. And speaking of lessons learned, I'm going to turn it over to Kathy Gerwig, who will talk broadly about lessons learned from the pandemic and safety.
Thank you so much, Mary Beth and Jeff. You both did a wonderful job describing the really enormous challenges faced and how your organizations met those challenges. And I wanted to talk about how we can use these important lessons to think about improving safety in the long term for the healthcare workforce. Atul Gawande wrote an article in the New Yorker on May 13th, and he talked about a combination therapy for reopening after the COVID lockdowns, and he described it being like a drug cocktail. You've got hygiene measures, screening, distancing, masks. And his point was if you skip one, the treatment won't work, but when you take them together and take them seriously, they will shut down the virus. And so let's think about what the combination therapy is for workforce safety in this time of COVID and in the future. And I think hindsight is going to show that organizations that had really strong workforce safety systems will be the ones that met the COVID challenges most successfully. And senior leaders, when they're facing intense ethical dilemmas, the moral distress Mary Beth talked about, PPE shortages that Jeff talked about, conflicting regulatory measures, and so on, absent a very strong system, those organizations had a multiplier effect of the problems that they faced. So there are 4 parts to having a safety system that's strong. One is to understand the risks and the hazards. I was thinking about some locations that went to PAPRs, powered air purifying respirators after Ebola and H1N1, and had very little fit testing for N95s and had to scramble to fit test hundreds of staff and they were lacking extra PPE to even conduct the testing. And that's an example of not having an effective pandemic plan that accurately identified the risks and the hazards. And the second piece to a system is once you know the risks and hazards have been identified, then you have programs to reduce and eliminate those risks. So this time it was N95 shortages, but what's the catastrophic risk and threat that we should be anticipating? And the role of procurement staff being engaged in staff safety planning became much more important. And how do we continue the role of procurement in safety planning? And are we ready for possible shortages in cleaning supplies, especially as schools reopen and other public venues? We've heard that employee health was not as robust as we might have liked, and how are we preparing for that going forward? Those are examples of reducing and eliminating the risks. And the third piece is to capture and analyze meaningful data. What are the leading indicators, especially? What could we have learned by including external scans of data? Infectious disease docs knew months before many of the rest of us about the threats coming from the global pandemic. And yet many of us were scrambling in March and April to meet the needs here. So looking at meaningful data means also looking outside, not just your own organization, but outside the U.S. And the last piece I want to mention, Jeff emphasized communication as being essential, which it is. And now with so many more teleworkers, that requires new ways of communicating, more frequent communication using videos to stay visible and engaged, leaders being available by text, having very clear goals and expectations around safety in a telework environment. Those are all examples of what we're going to have to address going forward in terms of communication. The second piece, so that's about having strong systems, and I want to touch on accountability because healthcare worker safety is the accountability of management, and it's all management, not the safety staff, but it's all management. And we need to integrate safety information into job descriptions, into leader standard work, into management practices, and into storytelling. Every management role has safety accountability, and the opportunity now is to clearly define that where we might have been challenged during this COVID crisis. And this is another opportunity to engage infection prevention more deeply in worker health and safety. We know that senior leader rounding and direct report rounding are among the most powerful tools around safety excellence, including psychological safety. And what does rounding look like going forward? This is an opportunity to more consistently round, ensure prompt and meaningful follow-up, especially with those that we're not seeing face-to-face every day. And the connections, Jeff talked about connecting patient safety and worker safety, and I want to also emphasize that. I would urge the lesson that this is an opportunity to define the synergies for our own organizations. So, for example, both worker and patient safety are based on safety science. They both can work together to enable essential behaviors like speaking up and encouraging psychological safety. They can both use similar leading and predictive indicators. You can embed safety for patients and workers into clinical protocols. Those are all examples of how worker and patient safety synergies can be better optimized. In terms of the third part of the lessons learned, so we talked about taking a systems approach, we talked about clarifying accountabilities, and the third piece of workforce safety is to successfully execute priority programs. And this means developing them, resourcing them, executing them in a way that equitably fosters safety. Examples of this outside the COVID realm are safe patient handling and slip, trip, fall prevention and ergonomics and needle stick prevention. The exposure control piece is the one that takes on new meaning given COVID and does need special attention. The other thing, we've talked a couple of times about telework, and it really is something to carefully consider around communicating with healthcare teams. And what are the safety implications to having more telecommuters and telemanagers? These are things like doing ergonomic assessments of their remote location, and what's the right seating and IT equipment for good body mechanics? What about lighting, climate control, egress, all the things you think about in a workplace, but when you're not controlling the remote workplace, how do you make sure that those things are safe? How do you make sure people have good, healthy work habits like stretch breaks when they're working remotely? How do you decide who is responsible for these things and who pays for equipment and other needs? So these are all questions to be addressed as we go forward. And my last slide is about some additional opportunities. We know that compliance with hand hygiene protocols is no longer a problem. There's much heightened awareness to hazards, and that's an opportunity to engage staff in identifying what are other hazards and what are mitigations. An example of something that would be great to do with staff is to engage them in doing job hazard analysis so that their voice is part of the solution. The second piece is that boards and senior management teams are much more attentive to workforce safety. This could be an opportunity to set a goal of zero harm for staff and patients. Or how about an aim to be the safest place to receive and provide care, and then establish the system and accountabilities and programs to achieve that excellence. We have an opportunity to integrate staff wellness with physical safety. Mary Beth talked about the well-being aspects of this, but often the folks who are thinking about wellness are not the same folks who are thinking about physical staff safety, and structures can be different in the organization. And with nurses and physicians experiencing very high rates of burnout, other indicators of emotional stress like sleep issues and so on, what would an integrated safety and wellness approach look like in your organization? And the final opportunity I'll mention is that COVID has been a catalyst for adopting new technologies and practices very quickly. And when new equipment or protocols are rolled out, it's essential to ensure that potential hazards for staff are identified and controlled. This can be done with speed, but now is the time to declare it will always be part of the work, that when new equipment and new protocols are rolled out, that one of the essential elements to that is keeping it on the road to zero injuries. So in summary, there's a three-part approach to safety around systems, accountabilities, and programs, and the lessons of COVID bring these into, I think, sharper and more immediate focus and offer an opportunity to strengthen the weaknesses that we've identified in our systems and to emerge with excellence and safety for those who receive and provide care. Thank you.
Thank you, Kathy, and before Kathy, Mary Beth, and Jeff, and Patricia. I guess I want to just note that I think, Kathy, certainly your points, I think, gave everyone some hopeful things to think about in terms of both what's been learned, what is being learned, and what happens next. This is your opportunity, everyone who's joined the program today, to ask questions of our panelists. You just need to chat into all participants. We did throw into the chat a question that some of you might be interested in addressing, which is something that improved in your organization, or a new initiative or tool or bundle around these workforce issues that you hope actually sticks around going forward, even if it was developed on the fly? So let me, I'll start, and then hopefully you folks will follow me with some questions. I think that it's quite a choreography going on right now with so many issues and so much processing. And I'm not sure who this question goes to, so maybe you can all decide, panel, among you. Do you feel that some of the longer-term impacts of this pandemic, is there now it's sort of surfacing much more in terms of trauma, moral injury, moral harm? Do you think any of that can be anticipated earlier and thus may be mitigated earlier, or is this something that is just a kind of natural part of what happens when people have to rally under very, very hard circumstances? I'm not sure who might be open to tackling that.
This is Mary Beth. I'd be happy to answer
Thank you.
that. Ask my colleagues to chime in. I think it can be mitigated, and I think that we know that this is an issue. We can anticipate it, and so one of the big issues is, again, reducing the stigma and providing avenues for people to talk about what they're experiencing, and then being able to direct them if they might just need to talk more. They may need to have more professional assistance. But I think we know about it, and we can put programs and strategies into place now to try to mitigate some of that in the future.
Thanks. Anyone else? Jeff, any thoughts? Don't mean to pick on you. Jeffrey Ford? Yeah.
I totally agree. And those opportunities to really translate something that we started to do with the pandemic and really say, how do we make this an enduring feature to support the well-being of our frontline employees, and really explicitly tie that, as you said, to safety. And I think it's different, I think, than what a lot of leaders maybe have assumed, is that that well-being and safety are tightly linked. And at Parkview, we've been having discussions about, I've been talking with my colleague, our Chief Community and Human Resources Officer, about the tight linkage between employee engagement and safety culture. And that really gets to that, right? So am I physically safe? Am I psychologically safe? Am I treated with dignity and respect? Does my work matter? Do people appreciate me for who I am and what I do? And that's what leads to engagement. It also leads to robust safety culture. Mm-hmm. If people feel like if they're constantly psychologically burdened, if they do not have wellness, it's hard for them, to have engagement, and it's hard for them really to embrace safety culture.
Great. Kathy, any thoughts? Kathy Gerwig.
Yeah, I would add that in agreement with Mary Beth and Jeff, and also say that what organizations can be doing now is to do measures of the degree to which staff feel that they have the ability to speak up about issues or hazards or risks in their work unit. And if strong systems are in place to capture that information, understand and appreciate where there might be gaps in staff feeling like they have that ability, and closing those, doing that when you're not in the middle of a crisis creates a stronger organization and makes you much better able to move forward during a crisis. So I do think that there are some important lessons now to take forward, and that will enable you to, every organization, to respond better in whatever the next crisis is that might appear.
Thank you. Patricia, do you want to swing back in here? Some thoughts about the sort of early intervention and starting points, even if you're talking about well-being, not so much versus, but differently than safety?
Sure. One of the things that I think is really essential is that people have an opportunity here to understand and learn about the current state of workforce safety, both physical and psychological safety in their organizations. And I did chat in a question. I know it's hard to sometimes chat in when you're on a webinar and trying to listen, but I think one of the observations that I've had is that many of our colleagues, particularly those who work in safety and in quality, do not routinely collaborate with and engage with their folks in occupational health and other parts of their organizations that are fully focused on wellness and well-being. So part of what I see here, and we've talked about a total systems approach, is how do we not only architect and connect the lines between these different parts of our organizations, but how do we meaningfully engage with one another and understand what our current state is on the basis of not just my perspective, but the perspectives of other people. And I think to the points that we've talked about today, so important to understand that when we talk about workforce safety, psychological safety is incredibly essential in. So when we think about workforce safety talks and sessions, our focus has been on ensuring that that is front and center. It's critical that we have those physical and psychological safety for any joy and meaning in work, which is an area of focus that is a meaningful part of IHI's priorities. So I'll pause there, Madge, and let others jump in and respond to perhaps some additional questions. Thank you.
Thanks, Patricia. And again, encourage you, please chat to all participants. We'd love to know your thoughts and what's kind of resonated for you listening to the program. I know we're talking about the workforce. That's a big category. It encompasses a number of different roles and professions that have responded to this pandemic in some pretty direct ways. I'm curious, maybe I'll start with Mary Beth. Is there any point, is it important to make, to break it apart just a little bit? Is there something that we should be saying a little bit more about doctors or nurses or support staff in these things to help us even glean more insight?
Well, I do think that different disciplines are impacted in different ways. I mean, I think the principles apply to everyone, but certainly the nurse who's providing care in a designated COVID unit in isolation, for their entire shift, having difficulty managing some restrictions and having probably in our organization over 300 new practices just specifically in a short time period coming at them. That's a different type of stress than someone who is working from home. However, the person working from home is also feeling stress in terms of not feeling as connected and not having social interaction. So I think there are differences and there are different strategies. And I do think that we have to tailor our approaches to specific roles and understand how this pandemic and how workforce safety impacts each person.
Do you think, either Mary Beth or anyone else, that some of the processing, being more open, the psychological safety that's done together across all these professions and roles, or is there some value in some of people in some of the more like-minded roles that they played doing that?
I think that's universal. We need for everyone to feel that they can speak up. We need their ideas to help improve safety, and no one has better ideas than the folks that are doing each of their roles. So I think that is an across-the-board piece.
Okay. Anyone? Go ahead, Jeff. Yep.
Yeah, this is Jeff. So I certainly agree that there's absolutely a universal need for that. However, I think, just thinking about it from perspective of physicians and advanced practice providers, I think that the culture of medical staff has not been one of wanting to speak up about emotional well-being. And I think that there often needs to be special consideration about how you can facilitate that and provide a level of psychological safety to help medical staff, providers participate in those discussions and encouraging them to be part of that larger conversation.
That's a great point, Jeff.
Yeah. And Jeff, I'll just maybe follow on. Do you think, even though burnout is certainly talked about in terms of doctors and nurses, but just sticking with doctors for a moment here, do you think what's gone on the last few months will impact even that focus and language and kind of what needs to happen to address these issues? Will that be reshaped in any way?
Well, the pandemic has certainly put frontline providers, doctors, nurses, respiratory therapists, allied health professionals, everybody at the front line under just extraordinary stress. And in many areas of the country that had high levels of COVID-19 activity, essentially they've gone through these experiences that were just like nothing we've ever seen before, nothing that anyone had ever experienced professionally in the past. And it's a real opportunity to recognize that, acknowledge it, and start dealing with it. And, that sort of context of that shared experience, shared suffering, in fact, can open a door to be able to get people at a point where they're ready to maybe engage with peer support and other opportunities, wellness, employee assistance programs, where maybe people were reluctant to do that in the past. So I hope that would be sort of a silver lining with the pandemic, is not only that people would have a greater willingness to engage and maybe through that shared experience be able to start embracing, acknowledging those stressors, but then also that hospitals, healthcare organizations, health systems are really looking at the way those services are provided and how that outreach is occurring to make sure people have access to what they need. Okay.
Well, there is somebody in the chat asking about learning more about employee well-being and safety. We actually are getting to the end of the hour. This was something that maybe either Kathy or Mary Beth might be able to answer. Perhaps we might throw into the chat there while I'm wrapping up. If anybody wants to maybe throw in a few ideas to answer that person's question, then we won't keep people beyond the scheduled time. Thank you, listener, for asking that question. So at this time, so we have kind of reached, an hour goes by very, very quickly. Big topic, lots of different issues. Hopefully people have some things to act on and think about. We are now posting some of your instructions for receiving your continuing education credit. These also get emailed out to everyone who attended following this program and this virtual learning hour. I want to extend a big thank you to Jeffrey Board, Kathy Gerwig, Mary Beth Kingston, and Patricia McGaffigan for their presentations and all the influential work that's going on in this space. You just got a flavor of it, but there's a lot more, and hopefully we can come back to it. Thank you all for joining us today. It's a pleasure and an honor to host this program. I'm your moderator, Madge Kaplan, and this does conclude today's Virtual Learning Hour. Thank you.